Yours is beautiful and wonderful. Ours is cheap and ugly. Now, our president in the United States has made all of his money in construction. So he wants to learn here from China, and this is what I feel he is going to do. This is the next greatest Trump construction project, the new Mexican-American wall, built on your model. So what I would like to do in my lecture is 5 things. I'm going to present a case. I'm going to ask by show of hands, because I see we do not have an audience response function here. And then I'm going to review the data, say what the guidelines want us to do, and then tell you what I do. And then we'll have discussions. So I want to start off with paroxysmal atrial fibrillation, because that sets the case for persistent atrial fibrillation. So this is in patients who have had no prior drug therapy, but present with paroxysmal atrial fibrillation. Do we use a drug, or do we go with ablation? So here's my case. A 56-year-old man with symptomatic paroxysmal atrial fibrillation who has a completely normal heart. I'm going to ask you by show of hands to tell me how you would like to approach this patient. 1, I would recommend using a drug to try to keep this patient in sinus rhythm. Or 2, I would proceed with an ablation. So how many say 1, I would use a drug? 1. Hands up, please. Okay? And how many would proceed with an ablation? So we have a mixed bag. Let's try to see if we can figure this out. If we look at some of the paroxysmal AFib studies, and you look at atrial fibrillation burden, you can see in the Mantra trial there was no difference when the burden was looked at. For recurrence rates, however, drugs did seem to be inferior to atrial fibrillation ablation. We look at the RAAFT trial, you can see in terms of first recurrence or first symptomatic recurrence, ablation overall was better than was proceeding with antiarrhythmic drugs. In the recently published guideline statement from Heart Rhythm Society, you can see, looking at those who had the low success range with ablation versus drugs, or the high range, taking all those studies into account, that overall ablation seemed to have more success than did drugs, although that's not the only way by which we make our decisions. In this nice meta-analysis, you can see that when they looked at that, ablation seemed to be favored for recurrent atrial fibrillation and for symptomatic atrial fibrillation, although the latter did not reach statistical significance. Now, if we look at it, the third thing then is, what do the guidelines, which are based on review of all the literature by experts, and we have several people on this stage who have participated in these guideline writings for programs. And if you look at, for paroxysmal atrial fibrillation, if you're intolerant of a drug, or if you have had a prior antiarrhythmic drug, they're both appropriate. Although the evidence, and therefore the recommendation, tends to favor more using ablation as a second-line therapy and starting a drug first. So both are acceptable, but there's a tendency in that direction. And it will come up in the discussion, I would think. So what do? I go to ablation or drugs based on the following general characteristics. And I'd love to have input from my colleagues to see if there are international differences or personal differences. I tend to favor ablation in people who are young, active or athletic, who have tachybrady syndrome so that I can avoid a pacemaker, who have more atrial fibrillation, characterized by longer duration or more frequent AFib, and those in whom a drug might be contraindicated. Most importantly, I want to engage the patient. I want to make sure that when we make the decision, we are both very comfortable in how we want to go forward. So Sun Tzu said, opportunities multiply as they are seized. We need to seize the opportunity and figure it out by working with our patients together. It is a joint decision. So that's the paroxysmal approach. Again, I'll use that same 5-component approach in presenting this case. Persistent atrial fibrillation, but now a normal ventricle, normal heart. Same case, generally. 56-year-old man, he is symptomatic from his persistent, not paroxysmal atrial fibrillation. His heart is completely normal. Now what do you do? Number 1, I will go with a drug. How many say I prefer to start off with a drug? So we have 4 people on the panel and nobody in the audience. So that will be an interesting discussion. So how many people then will go with an ablation? Okay, but some people are undecided, which is understandable. So let's go forward and see where we stand. Well, if we look at some of the persistent trials, there is the SARA trial, in which ablation was demonstrated as superior. There was the Fontero, the diabetic trial, which you can see, again, ablation seemed to be more advantageous. Then there was the TTOP trial, where, again, ablation seemed to be better in terms of ending outpoints compared to antiarrhythmic drugs. And then if we look at the trial from Europe, the oral trial, again, atrial fibrillation seemed to be better. Now, all of these trials had problems. They were small. They had different endpoints. They had different mechanisms for defining success. So none of them are perfect. They all had their significant limitations. But we have to sometimes make data on incomplete and less than perfect data. So if we look at the studies that I put together, ablation tends to have a better success rate with a multitude of definitions than drugs. But when we ablate someone, we are not usually just doing it to remove from the monitor atrial fibrillation or from the EKG. We want to make patients feel better. So if you look at this very nice meta-analysis that was done by Ciantis, and if you look at ablation and quality of life, the quality of life seemed to be better. Presumably because there was less atrial fibrillation, maybe with less atrial fibrillation, less rapid rates, maybe more coordination of the function, maybe a placebo, we don't know. But there was certainly a tendency in multiple studies consistently for atrial fibrillation to be better. So what then, fourth point is the guidelines. What do the guidelines tell us to do? Well, we already looked at what happens for AF. And if you look at, for persistent AF, again, class 2A indication. So it is reasonable to go forward. But there is more evidence in favor of starting a drug first and then advancing to ablation if you're intolerant. Now, we have difference of opinions, and I hope that we will be able to discuss that during the Q&A. So moving forward, what do I do? What I do first is, if there is no contraindication to drugs, I tend to prefer it again in the young, those who are athletic or active, and those, again, in whom I want to avoid a pacemaker if they have tachycardia syndrome. Once again, taking into account the preference of the patient, basing it on discussion with them. Albert Einstein said, we cannot solve our problems with the same level of thinking that created them. So we have to start thinking out of the box. We have to start questioning what we do, whichever direction we go. The third part of this presentation, persistent atrial fibrillation, now with heart failure, with a weakened heart. Same 56-year-old man, but this time his ejection fraction is now reduced 30%, and his atrium is somewhat enlarged. So now we're addressing, will putting him back into sinus rhythm help his heart failure, help him feel better, maybe even improve his longevity, or not. So in this population of patients, choice one is start with an antiarrhythmic drug. How many people would start with an antiarrhythmic drug? Okay, how many people would go with an ablation? Good. We have a little mixed opinion here. The ATAC trial, Luigi DiBiase put together, showed using as an endpoint freedom from AFib and atrial tach, that ablation was better than amiodarone. When they looked at secondary endpoints of hospitalization and of mortality, again, atrial fibrillation was better. The recently published or presented, and has received a lot of press, is the Castle AF trial in Europe. The primary endpoint was a composite of mortality and heart failure. And if you look at it, ablation was better for that composite endpoint. When broken up, you see on the left-hand side rather than the primary endpoint, but on the right you see the secondary endpoints. And for both of them, all-cause mortality and for worsening heart failure resulting in hospitalization, ablation was better than was antiarrhythmic drug therapy. So how do we approach it? And if we look at it a little bit further, you can see here that probably derived from the fact that the people in Castle AF had less burden from atrial fibrillation when they were treated in that approach versus when they were treated with the drug approach. Now, it was a relatively small study, and if you look at it, there were differences here. Most of the patients had paroxysmal, persistent AFib, and it was statistically beneficial. If we look at gender, there were only a small number of women, and there was no benefit there, but too small to say for sure. It was just underpowered. but for males, it did seem to be beneficial. For younger patients, because the mean age was 64, it was advantageous. And then if you looked at the level of New York Heart Association symptoms or the ejection fraction, it was better in people who certainly were symptomatic, were not normal, but not too far advanced in their heart failure. So some of the PAF trial, for persistent AFib patients with heart failure, seemed to be better in younger patients, those who had class 2 heart failure, not quite as advanced, and a slightly better ejection fraction. And we have evidence for males, not as much for females. So if we break that out, what do the guidelines tell us with persistent atrial fibrillation and heart failure, left ventricular systolic dysfunction? What they say is a direct quote, is it is reasonable to use similar criteria for atrial ablation in selecting patients with heart failure as without heart failure. Although I'm not sure that all of us do that in our clinical practice. So I tend to, again, assuming there are no drug contraindications, go for ablation in this group and those who are young. I tend, if I can, to use the drug first. And if we look at the guidelines, as you move from paroxysmal to persistent to long-standing persistent, the level of evidence and the recommendation tends to get a little bit softer as you move further down the road, suggesting that primary intervention with ablation for those patients who are new with paroxysmal is better than those with long-term persistent AFib. So Kung Fu Tzu said, be the change you want to see in the world. We've got to do more research and find out what we want to do and how we can do it better. I want to finish up with a quick set of discussions on the world real challenge. So most physicians and institutions do a good job, or we do not enforce high standards. What is your opinion about how we do around the world with AFib ablation? So 1, raise your hand if you think we all do a pretty good job. 2, raise your hand if you think that we really don't effectively enforce high standards. So not a lot of voting. People, and a lot more, per doctor, per institution than in the U.S., where it tends to be spread out. So if we look at this national survey here, and then we look at the guidelines putting together, there are still complications with atrial fibrillation ablation. Vascular complications in PAF we can usually take care of. They're problematic in the short term, but they're usually not associated with long-term sequelae that are problematic. However, neurological concerns and in-hospital death are really problematic. This is a procedure designed to make people feel better. So if you have a persistent neurological defect or you die from it, you have not done the right thing. And although these data come from very large databases, you can still expect a 1 to almost a 2% complication of this serious problem. So we've got to be careful when we engage our patients that we do it for the right reasons. So Charles Darwin said, it is not the strongest of the species that survives, nor the most intelligent, but the one most responsive to change. I think we need to move forward and do atrial fibrillation to help our patients. We need to do it for the right reasons. We need to do it better so that together we can aid and make it a better opportunity for our patients. So my summary thoughts are it has an important role in patient care. It can be primary or secondary after drug failure. In making those decisions, probably it is best if you're going to go primary to look at paroxysmal, first, persistent, then long-standing because of the success rates. Always look at the clinical condition and tolerance of the patient and engage the patient to see where that patient's preference lies. We need as institutions and as societies and as countries to be accountable so we have good success rates and low complication rates. And we need to work together across the globe to develop better quality and technical improvement. So this is not the only problem we have to deal with. How do we create peace? There are a lot of problems in the world. Do we have dialogue like we're having here? No. This is how we solve it. Look very carefully. We have new haircuts. That will make the world that much better. So we can build bridges and should build bridges. We have an ocean that divides us, but we have friendship that unites us. And if we walk across that bridge and shake hands, we will get better off. The good physician treats the disease. The great physician treats the patient who has the disease, said Sir William Osler. So I want to thank you very much for this invitation, Checheni, and it has been an honor to be here. Thank you.